My name is Dr. Laura Hancock, and I am a general dentist in Union County. And I've been honored to work with the Foundation for a Healthy Kentucky for a long time. I can't even remember. But I'm really proud of the work and especially enjoy seeing all these faces again after so many BOSE forms that we've been stuck behind the computer. So today we have an amazing panel of folks that are going to be dying to answer your questions. So if you've ever had something burning in the back of your mind, today's your day. So I'm just going to kind of introduce everybody and how we'll kind of go about things. We will have a presentation first with Matt Coleman, who is with the director of the Kentucky Office for Rural Health. And he works closely with Dr. Fran Feltner, who is the director of the UK Center for Excellence. And so they are going to present some information to us today to really kind of get us thinking about ways that we can target these gaps that we know that we have in our state. Then we'll kind of move down the line. We'll hear next from Representative Ken Fleming, and then Dr. Don Neel, and then finally Dr. Pam Stein. And after each person kind of gives their perspective, we will then kind of wrap things up by hearing from you. So we would like to kind of have a question and answer time to where we can kind of follow up, plant some more seeds, and get ready to dig in and do the work. So I'll just kick it off to you, just Matt and Dr. Feltner.
Go ahead. Okay, we're going to sit here. I'm not sure where the best place is to sit. I'm going to stand up here where I can see the slides, but because all of you all look like angels out there, like you have wings and very nice halos above your head. So this is coming from the Center of Excellence in Rural Health, where we do workforce studies to look at what our needs are across the Commonwealth. And so our job today is just to give you a little background of why we're here, look at where some of the needs might be, and always remember that data just gives us information to give us like a guideline of where we need to go and what we need to do. So that's where we'll be. So these are our methods. Of course, in research, this is what we do. And I have to say thank you to Sydney Howard, which is our analyst at the Center of Excellence in Rural Health, that helps us to provide this for you today. So each year we obtain the licensure data from the boards, the Kentucky Medical Board, the Nursing Board, and Dentistry, and others as we need them to look at what programs we need to bring to the Center of Excellence in Rural Health and what the state needs across the Commonwealth. So that licensure data is cleaned. Duplicates are removed. We look at urban and rural. We look at based on the age and the licensure was obtained, subtracted from the year of the licensure record really quickly. And start out with how we select our primary care physicians in this study. They have to have an active status in Kentucky. They have to be working here. They have to be either hospital-based, private practice, adolescent medicine, family medicine, general medicine, internal medicine, and pediatrics are all included in the data as providing primary care. When we first look at this data and we look at how many physicians are practicing in Kentucky, pay attention to the little diagram up here that shows you how many are practicing in their designated areas. And you look at rural, you look at urban, you look at Delta, and you look at Appalachia. And you can see that only 3.6% of our Kentucky physicians practice in the Delta region. That is the smallest region, farther west that you can go. And so you can definitely say that there is a need for physicians there. And then when you look at the ratio of how many providers see how many patients, and you look at urban, if you're working, we talked about this a little bit this morning, if you're working in the urban area, a physician's ratio is just 1 to 1,500. As you move into rural, it gets greater, 1 to 1,900. Appalachia, it's 1 per 1,800 people. Delta, it's 1 per 726 patients, according to the data that we have. So it's not only you have to take care of more providers or more patients in those areas, and then we talked about reimbursement this morning of primary providers, so that has a lot to do with getting them recruited there. So when you look at the total, as you look at most physicians practicing in Kentucky have been licensed more than 11 to 20 years. which is 26% of them. And almost a third of the physicians have been licensed between 31 and 50 plus years. So we're looking at an aging population of our primary providers. Only 17% of them have been licensed less than 10 years. So if you do the math on that, you could be the wizard to say, we don't have the young ones that are going to replace the older ones that will leave our system. And then here's a nice little map. I love to look at the map, and we colored it purple a few minutes ago. Now we're going to color it blue and gray. But you can look at the distribution of physicians by county, and you can see where the most of them in the darker areas have the most physicians that are serving the patients there. Then when you, whoa, what happened? I went, oh, no wonder that happened while I go over to somebody else. Sorry about that. Your all's eyes between the light and how fast I just went, you probably just had a seizure. Okay, how many physicians do we have in here? Do I have somebody take care of people with seizures? Okay. There's a total of 8 counties without a primary care provider at all. And you can see where those are listed there on the map. And, you know, that's really an issue that you look at. And then when you look at where clinics are, you look at where hospitals are, you look at where these providers are, there really is a shortage and not at all in some of our counties. So then you look at the following that illustrates the physicians that track over a 5-year period, and you look at from 2016 to 2022, which is our last licensure data that we just got. The largest tracked increase was between the years of 2016 and 2017. Then you look at the largest tracked decrease was between 2018 and 2019. It's going down. Across the 6-year span, a net loss of 258 physicians and a net gain of only 30. That tells us we've got some work to do. Now we'll move on into nurses, and we just heard from AHEC about their nursing track and how wonderful that they're working in that area. But this is data from 2023. And we have 69,000 RNs and 2,403 APRNs providing services in Kentucky. And when you look at their work setting, it divides out to where they're working in the office, where they're working in the hospital inpatient, or ambulatory care. And then the population foci that they have is family medicine, anesthesiology, and family psych and mental health. Look how low that is in mental health, and look what our mental health problem is today that we're looking at. I think that was mentioned also a few minutes ago. And then when you look at rural and you look at the nurses, 38% of them practice in rural, 62% practice in urban, and in Appalachia, 25%, and again in Delta, 10.2%. So, you know, we have to look at our state, across the state. We have to look at all of our regions and be able to see where the needs are. And that's why every data collection or every data analysis that we do at the center involves across the state. Then we get into dentists, and we're going to have a wonderful presentation here about dentists here in just a few minutes. But there's 2,546 dentists practicing in Kentucky. And the majority of them are located in the urban counties. And you'll see this here in just a second where the shortages are. So take a look at this diagram. 72% of them are in urban, 28% in rural, 17% in Appalachia, and 8% are in the Delta region. And I can tell you by trying to get access to a dentist for patients in Eastern Kentucky, there is at least a 3-month wait. The providers that have dental services there will not see any new Medicaid patients. They only take the Medicaid patients that they've got at this point and will not add any more Medicaid patients. So it's almost impossible to get an appointment for a child that needs into the dentist. And we're doing something about that, but we'll go ahead because my job is to show you the bad picture here, and then she's going to show you all the good stuff. So dentists, when you look at rural, the number in the counties by geographic, rural, number of counties with a dental shortage, there's 20 of them located in rural. In urban, there's only 7. 15 of those counties are located in Appalachia that have a shortage, and 9 of them are located in the Delta region, and here's the map that shows that. 75 of the 120 counties in Kentucky, 63% of them have between 1 and 10 dentists. 41% of all Kentucky dentists practice in Fayette County, 16% in Jefferson. 41 Kentucky dentists practice in Fayette County, 16%, and in Jefferson County, 25%. I think I have a boo-boo there. But you can see the map. So at this time, I'm going to have Matt come up and talk about loan repayment. What are we doing about it? What are we trying to do to recruit and retain the providers that we need in Kentucky?
All right, so I get to kind of share some of the better aspects of this. Now, we don't see this as an overall solution. We've been talking today about workforce, and this is more of just a tool in your toolbox. So at the center and the Kentucky Office of Rural Health, we have a couple tools that we're hoping that'll help build not only recruitment, but this is another retention tool that we're able to offer. And so hopefully this is something that you can take back and say, hey, this is out there. So there are 3 different loan repayment opportunities. One of them, not on this list, is the National Health Service Corps loan repayment program. And so that is actually a federally funded, federally run program. It's got a lot of obstacles and some red tape, and we'll talk about that in a minute on limitations. But then there are 2 others. We actually flip-flop the dates on these, so if you don't get, like when you look at this slide, real quick, so we have the Healthcare Worker Loan Relief Program of the Commonwealth. So that was actually the most recent. That was state-funded, and it was started just in this past year. It was recently funded by the state legislator, and we really appreciate that because we've started some great work with that. And then there's also the Kentucky State Loan Repayment Program, which is administered by our office, Kentucky Office of Rural Health, but it's funded through federal dollars. So kind of going through that, just in general, here's some of the current numbers. So we have a 20-year history of running the Kentucky State Loan Repayment Program. And what that started out with is it started out with a smaller number, and we've been able to build upon that every few years when we're able to reapply to the federal government over how much funding we're able to get to provide loan repayment. We've actually been able to provide 169 providers over the 20 years within a healthcare professional shortage area throughout Kentucky. And so there's a kind of a breakdown. One of the key ingredients of the Kentucky State Loan Repayment Program, our program, and one of the requirements of it is that it requires a match by the provider's organization. So whatever funding that provider gets, so if it's up to, let's say, $20,000, they get $20,000 from the loan repayment program. They'll also get $20,000 from their provider. So it's kind of doubling up that match, that amount, giving them more towards their student loans. So there's kind of a quick breakdown. And so recently, what we've been able to do with both of these programs is kind of start bringing in some of this data of what is really going on and what kind of picture do we have currently. So we actually received recently an increase not only in our state loan repayment program funding, but also the Healthcare Worker Loan Repayment Program of the Commonwealth. We've been able to use those funds in order to work together and collaborate. And so if you've ever taken a federal program and taken a state program, they really mesh together well, right? Yeah, that's exactly what I thought. So part of this is we've spent the last little over a year just talking and trying to sit down at the table and figure out how are we going to mesh these funds and be able to stretch both of these dollars into what we're able to do to better serve our Kentuckians that are providers with loan repayment. So right now, here's the current picture of this past year and what we've been able to fund. So we actually have some really cool things going on there. And so recently, here's another quick tidbit of fun information. So we went back and looked at the KSLRP, the student loan repayment, the federally funded dollars. We looked at the past 70 providers that we funded, and we have over 80%, or we have around an 80% retention rate on those providers, which is an excellent retention rate. If you talk about we're talking constantly about providers leaving that rural area, moving into an urban area. So we're seeing productivity of this coming out. We're seeing it. We're starting to dive a lot deeper now into some actual statistics of it and some of the how it's working. So here's kind of what we have as one separate program, and then how we've been able to build upon that. And if you take a look, you see that dark sector right there in the middle. This is actually Fayette County. You're thinking, oh, Fayette County, how do they have a loan or a shortage of providers? Well, what we wanted to do this past year when we applied for federal funds is we wanted to focus in on behavioral health. If you think that your county has a shortage of behavioral health providers, give me a raised hand. That should be every single person in this room, because every single county in our state has a behavioral health provider shortage. So what we did is we actually partnered with Eastern State Hospital, and we're able to provide loan repayments funds for their workers. And so we immediately had them contact us back and say this was an immediate retention. They said they had people walking out the door that turned right back around because they got those funds. So that's one of those like cool, like here's your anecdote story of it. But as we're getting the data, we're also seeing these results. And then here's kind of our funding. We've been able to see as we've increased. There at the bottom, it's kind of misleading with the $1 million because we're actually combining last year's program and this year's. It's one of those like federal funding, like funsies kind of thing. So continuing forward, we have over $700,000 that we are putting back into the loan repayment. And then so what we have is we have citations and links to all the reports that we've been using. Also, real quick, as we're talking about, I don't think I'm like way over time, I'm sorry. But what we've been able to find is there are limitations to each of these programs. So if we talk about National Health Service Corps, I mentioned that, federally funded, federally run. That kind of tells you right there, there's some limitations quick off. The involvement that it takes to apply for that, you have to have a site application and run through a lot of paperwork through that, and then you have to apply as a provider, and then the application cycles are never the same. It's always different. It's always rotating on a different schedule. It's kind of a fun thing to deal with, right? So there's the National Health Service Corps. Then we have the state loan repayment program, and one of the things that we found was a challenge or a limitation to our program is that match, right? It's great to have because the provider is able to get twice the amount. But the problem that we have is there are also providers that cannot get that match. So that's kind of one of the limitations. A couple others that bring out is just the limitations of what we're able to fund. So we're not able to go to the VA and say, hey, we want to fund some of your providers at the VA because it cannot be a specific patient base that they see. It has to be general public. So there's some different, just because it's federally run. So the cool part is what we've been able to do with the state funds and the healthcare loan relief program of the Commonwealth is we've been able to take that to stretch and use as the match for the providers and organizations that are smaller. For those of you who don't know, we have over 300 rural health clinics in the state, which is #1 in the country. We have more rural health clinics than any other state in the United States. So a lot of those rural health clinics are going to be your smaller clinics. So what we've been able to do with state funds, or what we're starting to do with state funds, is identify those clinics that want to offer student loan repayment and offer that as a match in order to stretch both the federal funds and the state dollars. So there's information there if you want to continue to learn more about student loan repayment. Feel free. One, it's just a quick Google. If you look up Kentucky State Loan Repayment, we're like first, second, third link on there. Also, I have to thank Janice Vance, who is our CaseLerp person here. Feel free to drag her away and talk to her about any of this if you have further questions. So I'm going to kick myself off the stage. I'm sorry for taking so long.
Thank you, Just Matt. We appreciate that. All right, next up we're going to hear from Representative Ken Fleming, who represents the 48th House District, which is part of Jefferson and Oldham counties. And he is currently, he was elected in 2016 and serves on the following committees: House Appropriations and Revenue, Budget Review Subcommittee on Health and Family Services, Finance and General Admin Pension. He's the chair of that one. He's on Health Services, the Public Pension Oversight Board, Legislative Oversight and Investigation, and Transportation Committee. He also loves to fly, so they put him on the Aerospace Aviation caucus as well. So he also has been instrumental in healthcare, workforce, aviation, mental health, and tax reform legislation, and is the executive director for Kilgore Samaritan Counseling Center, which is a not-for-profit mental health center that helps patients navigate all those mental health challenges. So thank you so much for being here today.
Thank you very much. I sure do appreciate the opportunity to come before y'all and talk about the workforce. And My background, for the past, 7, 8 years, I've been running a mental health center nonprofit and gotten a really big eye-opening experience when it comes to providing health care. And we have to find I'd say about 25 to 30% of my budget each year in fundraising activities because Medicaid reimbursements is where we know that's in the tank. But in any event, we're trying to work on that in a General Assembly. But I wanted, I just want to talk to you about a particular bill that passed through the General Assembly in 2013. I'm not too sure if y'all know about House Bill 200, it's Healthcare Investment Workforce Fund. Have y'all heard about that or not? Good. We're good. Well, let me just spend just a couple of minutes, sort of pump up the volume and make sure you're very conscious and aware of this particular workforce initiative that we took on. Given my brief background of like 7 or 8 years of mental health, I was having a very, very difficult time in trying to find individuals to fill the need of mental health services, particularly in Jefferson County and Oldham County and surrounding areas. And I started finding out that there was more issues out in the rural part of the state, particularly when it comes to Eastern Kentucky and Western Kentucky. And we try to do some telehealth things to initiate that and worked up some MCOs. That didn't go as far as I wanted to, but in any event, back in late summer, in full disclosure, my brother's in the healthcare industry as well, and he and I were talking about his bill in Florida that basically is a focus on nursing, and they allocated, I don't know, $40 or $50 million in doing that. Well, we started thinking about that. I was like, you know what can we do? And I thought, you know what, nursing is very, very vital, but we need to expand that scope. So we put in this bill to look at and attract and try to give incentives to universities as well as individuals to fill the gap when it comes to nursing assistants or mental health professionals, dental technicians, all those sorts of things. And so what we've come up with is a public and private partnership the state will match dollar for dollar, and it'll be going to basically two buckets. The first bucket will be to provide scholarships to individuals, about up to 65% of that money that will go into this bucket. The other bucket will be around up to 35%, and that will go into equipment training for universities and training centers to bring in individuals to attract people to get them through the pipeline when it comes to the certification and license of the area of the professions. What we put in there is one thing that I know Florida didn't do, is that look at the areas in the Commonwealth where are we underserved in terms they actually need, but also where we are underserved when it comes to profession. And so we put in there guidelines for the CPE, that's the Council of Post-Secondary Education, who will oversee this fund. And what they will do, they will basically look at these grants that come in from the institutions or through the institution in terms of their own needs, but also through the scholarships, to look at where we can place or where they can place individuals that go into these professionals in those areas that are underserved. Part of the requirement is that they need to be a Kentucky resident, and they need to stay in the program up to 2 years after they graduate in order to not pay anything back in terms of what they received in their scholarship. So this particular program is quite unique. In fact, I just got word about a couple weeks ago that Kentucky, particularly Congressman Coleman, is going to introduce a national model based on this particular program that will go out and basically nationalize this particular public and private partnership. And I know he's been getting a lot of bipartisan approach in doing this, which is very, very important. And we had a great collaboration when it came to this particular bill. In fact, it took around 12 plus associations to coordinate first of all, to get people to buy off on it, which actually was a pretty easy sell, but also to get them to really push this hard. And like I said, around 12 association, And we got this through in 30 days. And that took a lot of teamwork and effort and phone calls and 1 o'clock in the morning texts that I received from people, but that's okay because we knew we were making an input. And we based our decision on doing this back on 2013 in Kentucky Hospital Association when they came out. I know there's a new report out. I have not looked at it, but it will provide a real good benchmarks for us to moving forward so we can say, all right, is this program, are we getting a return on our investments from a taxpayer point of view to making sure that, hey, this is working and we're going to continue to do this. So we put in criteria in the bill to make sure that CPE is held accountable, that they report back to General Assembly, and that we can make any adjustments or changes as time evolves and so forth. What we're looking at doing is allocating, and I've already talked to, as you said, I've been on the A&R committee for some time, and I've already notified Chairman Petrie. He's the chair of the A&R, and he's quite aware, and I know he's going to be very supportive of that. So we have gotten a lot of committee members that's going to be supporting this to put in $25 million over the next 2 years. So basically, it's $12,500,000 each year to do this. So with that, I mean, that's really a 2-for-1 leverage that we being the state government, putting in to have a public partnership and public sector to put money in there as well. In fact, Florida was so successful for them, they bumped it up to $100 million because it has such a demand when it comes to these different types of professions. So there's a lot of potential, there's a lot of enthusiasm, and I think this is really where the rubber hits the road in terms of providing or filling that gap when it comes to mental health, as well as health care across the board. So, it was a pleasure to work with you all. I think I heard maybe Senator Meredith may have mentioned something about being involved in the politics and the process. I can't tell you enough. I mean, prior to my life, when I was a president of our national association when it comes to aerial survey and mapping, we had a session with all members, about 1,000 of them, that basically go through. This is what you need to do on a consistent basis to talk to your representatives. I can't stress that enough. Because sometimes politicians get caught in a rut, in a hole, and starts hearing in an echo chamber, just like Twitter and so forth. But if y'all need to be involved, you need to listen. You need to come and express your voice, your opinions, regardless if it's a Democrat, Republican. Because healthcare is healthcare, and we all will find ourselves needing that some days at some time. And so having y'all involved in the process so we can hear what you're saying, what your needs are, that's what's really needed. And that's how this part of this bill, House Bill 200, came to fruition, because we started talking to folks out in the profession industry that say, we're hurting. And I said, all right, let's come up with something, and we came up with this. So anyway, I can go on a little more about this, but that's what it is in a nutshell. Like I said, it's the regulations that the CPE has gone through. In fact, they had a hearing on it yesterday. I haven't heard a report on how things went. But the CPE did a really good job, and really, it was a really pleasure working with them, because they opened up the process to make it as easy as possible, not bureaucratic, not a whole lot of red tape, when it comes to getting the private sector as well as the nonprofit sector into the system, into the process, to look at what we can do not to have so much of a regulated process in doing that. So that turned out to be really good. We're really excited about this, and hopefully it'll be come to fruition with the $25 million, which I think it will. Anyway.
That sounds terrific, doesn't it? Love that. Thank you so much. Next up, and we got to watch these two, because now that I've realized I got two pilots over here, they might switch their mode of thinking. But next up, we have Dr. Neel, who is a pediatrician in the Owensboro area after his service in the military, and he tried to fly south but came back home. So he's back in the Owensboro area and is a great champion for all things Medicaid. So, and children, and making sure they can have even their teeth fixed. So I love that. See, your brain and your teeth are a part of your body. So we require reforms that address all of them. So Dr. Neel, would you like to share some words?
Can I come up there? Good afternoon. Can you hear me? Okay, my voice is, I had COVID last summer, and I had the sorest throat I've ever had, and somehow it changed my voice, but I'm still got a voice, and I'm going to use it. So, a little bit about me. She told you some. I was fortunate to be in the first class to graduate from the University of Kentucky College of Medicine. That was a lot of years ago in 1964. And that school opened expressly to train primary care physicians to hopefully go back to their either city or county or wherever in Kentucky and provide care for Kentucky citizens. Since then, we've opened Pikeville, and of course we have the University of Louisville. So we have three engines putting out hopefully primary care physicians. And you'll have to pardon me, I'm still trying to program my Apple Watch so that every time I use the word provider, it'll shock me. Because I don't like to be referred to as a provider, and I don't like to use the word provider. I became a physician, and I consider myself a clinician and a scientist, and I don't feel that I am providing care to a customer. I feel that I'm taking care of families, whether I'm a pediatrician or a primary care physician, and trying to guide that family through wellness throughout their life. And by the way, I want to make a point very quickly that was made by Don Berwick a few months ago in the AMA Journal. And that's something I think we ought to realize, because we're here in almost the sickest state in the nation. We've got to understand that. When I went to Florida and worked for a few years, they would listen to me after I talked to them. They said, "Where are you from?" And I'd say, "Kentucky." And they said, "Well, do you all wear shoes and have indoor bathrooms there?" You know, you realize, I said, "No, we have really clean water, and we do pretty well here." But anyway, he pointed out that health is a summation of a number of things, and that we physicians, no matter how hard we work, are only influencing about 10% of overall health. Not health care, but health. The other 50% has got to do with genetics, and we don't have the best gene pool in the world in Kentucky, so we can't improve that too quickly, but we'll work on it. The other 40% has to do with how you live and where you live. And that gets down to what we need to really work hard at. When I became a pediatrician, I opened an office in Owensboro and became a solo pediatrician, just as most of the rest of us were at that time. We didn't know anything about business. We weren't taught in college or medical school anything about economics. All we knew was that we wanted to treat patients, and that if we opened our doors, they would come. And that's what happened. And when we answered the phone, we didn't say, "What kind of insurance do you have?" We said, "When can you be here?" And that was basically the way it started. And they came. And after that, we got accused of doing fee-for-service. That fee-for-service meant that if we wanted to make more money, we just saw more patients. That's not what happened. What happened was patients were beating our door down to see us, and so we had to see more patients, particularly those of us who were seeing Medicaid. And even in Owensboro, 60% of our patients were on Medicaid. This is in pediatrics. We were less than that. But now, if you'll think about it, as has been talked about earlier today, we have 1.7 million of our citizens who are on Medicaid, and about 60% of them are children, so we have well more than half the children in the state are on Medicaid. And now we have something called Medicare Advantage. And if you think about that, all that is Medicaid for the elderly. And since there are 1 million people in Kentucky on Medicare, that means that about 500,000 more are actually on Medicaid. Now, you might want to rebut that, but what I'm saying is that you give up your Medicare if you get Medicare Advantage. The companies are paid a per member per month, which we'll talk about a little bit later on some of these other topics. But so that means that we have well over 2 million of our citizens that are basically on Medicaid. So that says that we have a lot to do. I've been an advocate for Medicaid ever since we started. Up until the 1980s, we did quite well in our offices as individuals. We didn't have to band together. We knew that we could make a profit, but we mainly wanted to care for our patients. Then in the 1980s, something called managed care came along. That came along because big business discovered there was profit to be made in medicine. And when the managed care train left the station in the 1980s, physicians were in the passenger car. And we've been trying to get up to that mighty insurance engine that's driving the train ever since then. Because of that, we had to start to band together in groups. We hired office managers. We did those things that became more expensive for us to practice. And I point that out also because at about the same time, something called the electronic medical record was being pushed. And I remember getting cards and letters and phone calls about how I would be able to upcode and see more patients and do much better with electronic medical record. They didn't bother to tell me that it would be so expensive that I wouldn't be able to afford it. And unfortunately, that's what's happened now. And was said by, I think, Kevin this morning, whereas Google runs the internet, Epic runs the EMR world. I was fortunate to practice a few years in Florida over the last 7 years, where we had an electronic medical record where a pediatrician could easily see 40 patients a day, take an hour off for lunch, and be home by 5:30 if he could get through the traffic in Florida, of course. However, there are other ways to do it, and we still can survive. Now, to the heart of the matter, we have to do something because it's my feeling, and I'm optimistic, that medical students today really haven't changed. They're much brighter, much smarter than we were when we went through medical school, but they still want to serve the public, and I think they still have the desire to be autonomous if they could be. They know they may be working for other people if they're in certain specialties, but they'd still like to be somewhat autonomous. And it looks like that's fading away very quickly. But I'm optimistic that that can change if we change Kentucky. We have got somehow to improve what we do. Now, the medical home was invented by the pediatricians 50 or 60 years ago. And we almost put ourselves out of business with immunizations because that's what really got us going. And immunizations we developed an immunization registry a number of years ago, and that's one of the bright spots for Kentucky in the nation, is that we're in the top 10, I think, of immunizing our children. Also, we had to give them regular checkups. We had to give them sports physicals, school physicals. But the most important thing, and the reason that I argue against value-based care, is that you can measure those values that I just mentioned that we do. But how do you measure the confidence and trust that families put into their pediatrician and into their primary care physician? And I think that's the one thing that I have the most trouble with about value-based care. I hope that as we improve health care and as we practice wellness instead of sickness and sick care, that we can improve Kentucky and that we can encourage adults to have more of a medical home. I live sort of in a retirement community in Owensboro, and I can tell you that most of my neighbors who are mostly retired, intelligent folks who cannot find a primary care doctor. In fact, they don't know if their doctor is a doctor, and that's part of the problem. I trained in Colorado where the first nurse practitioners were created for the mountains of Colorado where doctors wouldn't go. For 30 years or more, helped train nurse practitioners, and they're absolutely wonderful. And we found that we could not find doctors to help us, so we started to hire nurse practitioners to take the place of partners, if you would. The problem that I see is that if we're going to hold quality care up, then we're going to have nurse practitioners practicing quality care just like physicians do. And I'm not saying they don't. As a matter of fact, I hopefully trained hundreds of nurse practitioners during my time, and I think they do an excellent job. My job now, because I still work for a group in South Florida, is to the first couple of years that we hire nurse practitioners, we look over their shoulder. And by doing that, I do that by my computer from Owensboro. And when they get out of the chart, I get into the chart, I have them on speed dial, and I have their back. And I wish some way in Kentucky, because so many places in rural Kentucky, particularly the federally qualified health clinics, are almost all nurse practitioners. And I wish in some way we could assist them, because part of the problem is they don't know what they don't know, if you'll think about that. I didn't know everything as a physician, but I knew what my limits were and how to get help. And so I don't mean that in a critical way at all, because they're my brothers and sisters in what we do for the citizens of Kentucky. So I've probably talked too long. The one thing I wanted to say, though, before I forget it, is in 1993, we created KINPAC, the legislature did. They wanted to assign patients so that they would have access to care. And that went on for a number of years until 2007. And most of us that had large Medicaid practices only were able to keep our doors open because of the per member per month. It was only $4 per member per month, but if you multiplied that by the 2,000 or 3,000 patients that we had, then we could keep our doors open. When we went to managed care in 2007, I begged the governor not to do it because I thought what would happen, and that is that we went from about 3% of administration for Medicaid for Kentucky to 18 to 20%, and I think that's what's happening now. We tried other things. We tried a provider tax, which also my watch would shock me for if there are any physicians here, because that's a dirty word, although the hospitals now have a provider tax that they pay. So that wouldn't work. But somehow we've got to help our primary care physician and our primary care workforce. And I think that's going to be to look at not just the money, but the burnout. We're not burning out because of the practice of medicine. We're burning out because of all the things we're having, the prior authorizations, the paperwork we have to do, working through lunch to just catch up with the computer, treating the patients as if they're a number. That's really a problem. Patients want to not be a number. They may want to look at my chart. They may enjoy some of the benefits of the electronic medical record. But on the other hand, it's very difficult for them to accept the idea that the doctor's treating the computer and not them. And I just want to make that point. So anyway, I'll stop now. I think too much time. Thank you.
I'm so glad that you didn't get electric shock too many times today. That's fantastic. Next up, we have Dr. Pam Sparks-Stein, and she is from Carlisle, Kentucky. And she is a dental rock star. So she is really taking this access point for oral health to the next level. And so I'm really pleased to have her here today speaking as the new dean of the Pikeville Dental School. And so share with us the ways that we're going to be so dynamic over there that everyone's smiles are going to be brighter.
All right. Thank you very much for allowing me to speak with you today. I'm really excited to have the floor to talk about dentistry. I came yesterday to our meeting about the Council on Post-Secondary Education's meeting on workforce, and then again today. And we really haven't heard a lot about dental. Sometimes I get aggravated. I feel like we just get to be kind of forgotten. And, you know, there aren't as many of us as there are physicians and nurses, and there's not as much need in terms of numbers for us, but we do play a very important role in promoting and maintaining health in individuals, and we want to be included in the healthcare team because we know that our role is important, and without good oral health, you really can't have good health. So thank you for letting me share just a little bit with you today. We do have a we have a problem in Kentucky with workforce for dentists. And you heard the statistics, how many different areas have a shortage of dentists. And I think what I see is that not only do we have a current shortage, but we have an impending greater shortage. In my previous role, I'm the new dean of the College of Dental Medicine at University of Pikeville. But prior to that, I worked 20 years at UK, and many of those years I was in public health, and for a time I was the chief of dental public health, traveled all over the state, from Fulton to Harlan to northern Kentucky, all over. And a lot of the counties that have dentists that are older than me, and I'm almost 60. They're not going to be in it much longer. In fact, some of those dentists closed their doors during COVID and just walked away. So I wanted to share with you one of the things that stays in my mind. I'm in Eastern Kentucky now. My family is from Eastern Kentucky and the west end of Louisville. Coal camp, urban poverty. Mom was a nurse, dad was a dentist. It was all about public health at the dinner table for me. But I really didn't have that much exposure to Western Kentucky. Spent a lot of time in Western Kentucky in the last 5 years. Unlike Eastern Kentucky, there are not as many dentists in rural health clinics or FQHCs. They have FQHCs in Western Kentucky, but they don't have dentists in them. And what that means is there's a terrible shortage of Medicaid providers for dentistry because dentists have dropped out in droves from the Medicaid program because of the low funding and the administrative burden, which we've talked about so much. So UK has a Marshall County clinic in the health department. 2 dentists were there, and part of my job was to oversee this clinic. I got there at 6:30 in the morning because the first part of their day they saw walk-ins, pain patients. 6:30 in the morning, there was a line out the door. I mean, you would have thought they're lining up to go to a UK ball game or something. Lined up. The door didn't even open till 7. And they had to turn people away every day. Why is this happening? So I'm talking to the staff, talking to the patients, and the individual who answers the phone said, when people call and say, do you take Medicaid and will you take my tooth out? And she said, yes. It wasn't unusual to have someone actually cry because they were so happy to have finally found someone to get rid of their pain or their child's pain or their grandchild's pain. People came from about 15 different counties to that clinic. So that kind of showed me the urgency of the need in that area, and we see that in the Delta numbers. In Eastern Kentucky, we have also a crisis. We do have federally qualified health centers that have dentists, but those dentists are overworked, and it's a 3 to 6 month wait sometimes to get in to see them. I've talked to so many different public health department directors and dental hygienists who work in public health departments, and what they're seeing with our children now in the school-based programs where they do prevention, they don't do definitive care, they're hygienists. What they're finding is since COVID is we have an exponential growth. And talking to pediatric dentists, they are swamped. So much more decay in our children, so much more urgent needs. Children with swollen jaws, abscesses, can't sleep, can't learn, can't eat. This is a medical problem. Children die from these problems. We've got to do a better job of getting our kids in to have these urgent needs met. There's a dentist in Eastern Kentucky, one of my colleagues that I talked to, who is very passionate about access to care. He sees kids under 18. I think he has edentulated, which means take all their teeth out. A kid under 18 that has to have all of their teeth out because they're hopeless, they're completely decayed, and so that kid at 15 goes into a denture. Not one kid, not 2 kids. I think he's had 5 this year. We're not in a third world country here. We can do better than that. We can do better than that, and we have to do better than that. I want to talk a little bit about hospitals now. This is something else that I found when I was working at UK in public health. I talked to a lot of medical directors at hospitals, and what they would say is, we need dentists to do clearance checks for our patients and to get rid of infection. In order for a patient to have cancer treatment or a transplant or life-saving urgent aortic procedures, in order for us to do those procedures, those surgeries, they have to have a dental exam, and if they have infection, that has to be resolved. We can't find people to do that. There have been people in this state who have died because there wasn't a dentist to do it. They needed a procedure, and they could have gotten the aortic procedure, but there was no dentist to check their mouth and to get rid of the infection, because we don't have enough dentists, and we don't have enough dentists that take Medicaid. And then the other problem in hospitals is the ER problem. If you have a toothache and there's no dentist, where are you going to go? You're going to go to the ER. Is there any definitive care in the ER? No. So what happens in the ER? You get an antibiotic and a pain pill. Well, that's a problem. Antibiotic resistance and drug abuse. And then it costs a whole lot more. $38 is what Medicaid pays to take a tooth out. Well, that won't pay for my PPE. This is why dentists don't want to take teeth out anymore. They don't want to take Medicaid. I mean, that's what it paid in 1990 when I graduated from dental school. You think the costs have gone up in the last 33 years? Especially since COVID. We can't do it. Addiction recovery. Kentucky has a big problem with addiction. We have a lot of great people doing great work in this area, and in my conversations with them, again, as I've traveled the state, what I have learned is that a toothache is a major risk for a relapse. Someone who is in the early stages of recovery has a toothache, that's a problem. What are they going to do if they can't get help, if they can't get the tooth out? Might they go back on the drugs for relief? And it also is, as you can imagine, and I know you've probably heard this before, but also workforce. It's an issue. Drugs are terrible for the teeth. I see many people who have had a drug problem and they're in recovery and now their teeth are just black nubs. Well, you can't get a job like that, you know? Thankfully, Medicaid has expanded now to include dentures, which is wonderful because we could take those teeth out. Most people who are in recovery have Medicaid, and we could extract those teeth if you could find a provider to do such a thing, but we couldn't replace them. So now you have someone with no teeth, which is better health-wise, but self-esteem and work-wise, not so good. So I'm thrilled that we now can make dentures. Kentucky has the highest rate of edentialism in the nation except for West Virginia. So that means we have more people without teeth in this state than any place else, except West Virginia. And next year, we'll probably be 1 and there'll be 2. We share that 1 and 2 slot. So we do need to be able to make dentures for patients. Solutions. One might say we don't need a 3rd dental school in Kentucky, and we heard we didn't need a 2nd dental school when UK was started. We're a small state, but we need dentists. And we have to graduate primary care dentists who will practice in rural communities. So that is really the goal of the new dental school at University of Pikeville, is to graduate dentists that will practice in rural and underserved areas of Kentucky primarily, but really it would be a win to have them practicing anywhere in a rural and underserved area, but Kentucky is where our heart is and what we're recruiting for. That's what we have a strategic plan for. So just the dental school itself will provide around 25 dental, not providers, dentists in the area, some specialists, a lot of primary dentists. So that's going to help in the area. We will also have a pediatric clinic with 8 chairs, a special need clinic with 5 chairs where we will treat patients with intellectual and developmental disabilities. And we're working to develop a relationship with the hospital to have a hospital clinic so we can solve some of those problems I just mentioned. We have collaborated with an addiction recovery care center, and we have a clinic inside of one of their facilities, and we're in the process of applying for funding to have mobiles. I really want us to have a fleet of mobiles, because sometimes you just have to take the care to the people. And especially in an area with the geography like we're in. You know, people sometimes don't have transportation, they're not well, they live in a very remote area, it's a problem to get out, they're older, they don't want to drive, they're in a nursing home. There are so many problems in just taking the mobile to addiction recovery centers. Wouldn't that be wonderful? Or to schools, to provide definitive care, not just to look in the mouth and say, oh my gosh, let me put a little fluoride on there. And don't get me wrong, fluoride is good, but if you look in someone's mouth and they have 10 cavities and 5 abscesses, they need definitive care. They don't just need their teeth cleaned, right? So we want to be a part of that solution. We have a unique recruitment strategy. This semester, we're visiting 13 schools in Kentucky, and most of those are schools like Alice Lloyd. In fact, we were there last night. EKU, Moorhead, Berea, Lindsey Wilson, Union, Campbellsville, Cumberlands, Murray. Did I say Moorhead? So you get the idea. We are going to small rural schools in an attempt to get students who go there to come to UPike, stay in a rural area, and then go back to their hometown. We're looking for people who want to serve. They're required to have 200 hours of service. That's more than the hours of shadowing. That's a lot of hours of service when you also have to have a really good grade point average and a hard schedule at school. We have a unique mission, and our mission is to, A, graduate dentists who will serve in underserved communities, particularly in rural Kentucky. And also, the second prong of that is we want to not just graduate dentists, that's our long goal, but when we start, we want to immediately begin seeing underserved patients. And that's why we're going to have the pedo clinic and the special needs clinic. We also will have, just like that clinic in Marshall County, every day we will see pain patients. And I suspect we will have people coming from counties all around to get their urgent needs seen. Our unique education model, we're trying to control cost. We're looking at the potential of a 3-year program instead of a 4-year program. I was very resistant to this because I practiced in the smallest county in the state. Anybody know where that is? Robertson County. I'm from Nicholas County, and that's adjacent. So I practiced in those 2 counties. When you practice in a rural area, you better know how to take a tooth out. You better know how to take out a difficult tooth, how to do a root canal, how to put a stainless steel crown on a child's tooth that's 3 years old and in Head Start. You got to know how to do it all because people don't want to go to the city. They can't afford it, and they don't want to travel there. So I know, because I was in private practice for years in a rural area, they've got to be clinically competent. And what does that require? Hours and hours and hours in the sim lab, in the clinic. Can we do it in 3 years? Well, I believe we can. Now, it's going to be hard on them, but dental school's already hard on them. It's going to be not 10 months, and we haven't gotten approval from the Commission on Dental Accreditation yet, but this is what we're planning to submit, 12 months. So 36 months versus 40, and instead of having some afternoons off, it's game on, 8 to 5. You're here to work. You know, we're not going to have a lot of breaks. You're at work. It's just like you graduate college, you go to work. You don't get summers off anymore. So, and I think that unique model will, A, reduce the cost of dental education, which is now over $300,000 in the state of Kentucky, just for dental education. That doesn't include undergrad. So we've got to do something about the cost, because cost drives practice. If you graduate with $500,000 in debt, you're not going to move to Paintsville, where there's 70% of the population is on Medicaid and accept patients for $38 to take their teeth out all day, or you're going to go broke. It is not financially sustainable to do that. We've talked already at length about the number of our citizens in Kentucky who have Medicaid. And it's just, you know, I have for years, I love rural Kentucky. I grew up in rural Kentucky. I worked in the tobacco fields, I'm ashamed to say. But hey, back in the 80s, that's what we all did. We had smoke breaks in my high school. Yeah, we did. The teachers and the students got 10 minutes to smoke every day. Well, they don't do that anymore. But the Medicaid, our reimbursement models really are very, very important. Our Medicaid reimbursement models are very important. It's so much of our population, and particularly in our rural communities. And I think we have a ways to go with medical insurance too. An infection in the mouth is an infection in the body, and it affects the body. We have so much research now, so much research that shows an infection in the mouth contributes to really bad problems in the body if it's untreated, whether it be an abscess, an infection in a tooth, infection in the gums, period disease, whatever. It really does impact general health, like myocardial infarction, strokes, diabetes, cancer. These are some of the Kentucky uglies that we have. We're way up or way down, however you want to talk about it, but we have a lot of health problems here. And taking care of oral health is not the only thing that's going to help that, but it certainly is part of the equation. And if we don't look at that and include it and start paying for it medically, I really think that we're not going to have optimum health. So my vision, and we're actually going to open, the board of University of Pikeville just voted 2 weeks ago to allow us to open an interprofessional clinic. So this is my dream to be involved in that, because I think if we have a medical school, an optometry school, a nursing school, masters of social work, and now a dental school. And the business school is getting involved. They're going to run it. So we're all going to be there. We're also going to have a pharmacy, and we're going to work together instead of being in our silos. Work together with the mental health issues, the medical issues, the dental issues, optometry. I think that is the way of the future. That's the way to really quality care. We want to do it. You want to do it. We want to provide the best care, but we have a lot of barriers. So I think the solutions involve partnerships, collaborations. It's a complex problem. We're going to have a multifaceted approach. We have to have new practice models. We have to have new education models, and we have to have new reimbursement models. If you want to talk to me about this at all, I've gone way over my time, but I really appreciate the opportunity to talk about oral health. And please, I do look at my emails and try to answer them every day. So if you're interested in this and you want to collaborate or just bend an ear, I would love to hear from you.
You know, I'd give extra time for oral health discussion on the panel. Are there any questions? We have time for maybe one or two. If anyone would like to come in. All right, I'm coming way down the stage maybe to pass you the mic.
Thank you. I would like to ask, have there been any new initiatives or inroads in reducing the role of chewing tobacco in dental health in our state?
There are some schools in Kentucky. There are some schools in Kentucky who now have a ban on that. So you cannot use it. Used to be in high schools, and still at some schools, they use it a lot in schools, and especially with sports. But there are some schools now who have bans on chewing tobacco. Do you have anybody else have any? That's a problem in our state, though. In fact, our state of Kentucky has the highest rate of tobacco use for our youth, 18 and under, of any other state in the nation. And that does include smokeless tobacco, vaping, smoking. So we have some challenges there.
Yeah. Well, doesn't the law about, only 21 and over, doesn't that also apply to the chewing tobacco as well?
Yes. But the problem is, what we have heard is parents and grandparents will buy that for their children. So it's kind of a cultural thing in some places.
This question is for either Dr. Sparks or Representative Fleming. What do you know about the status of the Cabinet for Health and Family Services initiative to cover dental, vision, and hearing under Medicaid? Where are we in that process? I know it's been started, I just don't know where it stands. It's my understanding that the Medicaid commissioner has applied for a CMS waiver to include hearing, vision, and dental in our Medicaid program to spruce up, if you will, beef up our commitment to those three aspects of health care. Do we know where that is?
There has been, I'll be honest with you, there has been some discussions in the General Assembly. There was a presentation, I want to say a month or two ago. I was not part of that committee. I wish I could answer that question to you more, but there has been discussion about that. If you want, I can get your name and I can get you connected to somebody who can provide a much better answer than I'm providing for you. But I know there has been discussions about that.
Do we have one more question?
I was just going to say we do have we do have a Medicaid expansion for dentistry this year, which has been very, very helpful. As I mentioned, to include dentures, partials, crowns, and root canals, which is great. That way, if there's a tooth that's infected, we don't always have to take it out. We can save it with the root canal and put a crown on it.
Anyone else? Okay. Well, I'm going to hand it off to Miss Allison.
Thank you all so much for being here. Just to remind you, if you don't know who I am, Allison Adams, the Chief Operating Officer with the Foundation for a Healthy Kentucky. I can't thank you all enough for coming to be back with us after 3 years hiatus of an in-person Howard L. Bose Memorial Policy Forum. So thank you very much for attending. Thanks to the panel, and thanks to all of those who have presented previous sessions. Want to remind you all that all the sessions have been recorded, and once they're processed, they will be sent out with your registration follow-up. Hoping that you are walking away with new insights and ideas and inspirations to take action. We at the Foundation believe every Kentuckian deserves to have access to high-quality health care that's all-inclusive health care. Dental, vision, mental health, everything that encompasses someone to feel healthy and wealthy and wise here in the state of Kentucky. And for that to be a reality, we must support the people on the front lines providing that care, and that was the intent of this policy forum this year. We have the opportunities to invoke big P and little p policy to support and sustain and optimize our healthcare workforce in Kentucky. And so we hope that you have got some ideas, you've got some opportunities for partnerships, forming those symbiotic relationships that it's going to take in order for us to improve those health outcomes in Kentucky. So finally, we'll be sending you a post-event survey that should only take a few minutes of your time to fill out. As with every survey, it's important for your feedback for us to build upon what information you want next year, what else the Foundation for Healthy Kentucky can do to you, do for you and for Kentucky to serve and improve the health outcomes and address the unmet health needs. We want your help to help shape the future, and we hope that you will continue to collaborate with us and reach out to us if there's anything that you feel the foundation can do for you. Lastly, we want to recycle your name badges. So on your way out the door at the registration, if you'll just throw in the plastic, if you want to keep your name, absolutely do that. We would appreciate the plastic tags. And with that, have a safe travels home. We really appreciate you being here. Thank you.